For this free paper session on optics and refraction and contact lenses, may I invite the chairpersons for the session, Dr. Mahesh Kumar Somani sir, Dr. Amit Kumar Mahajan sir, Dr. Meenakshi Wadhwani ma'am, Dr. Jatinder Bali sir, Dr. Ashish Bachav sir. Please, if they can be on the stage. I'll be the moderator for this session. Myself, Dr. Abhishek Onkar, faculty in charge in Department of Ophthalmology at AIMS Devgar. And
I'm Dr. Jatinder Bali.
sir.
And do we have any of the judges here, please? Who are the judges for the session?
I think the chair will be the. So the chair will have to judge, sir.
Okay.
And we have the list of.
All right.
I will
So
just get one
can
of
we?
these
Yeah.
more.
So Dr. Somani, Dr. Mahajan, Dr. Wadhwani, Dr. Bachav, Dr. Onkar. Anybody here? All right. So what this says is we've got a total of 100 marks where content carries 25 marks, presentation carries 25 marks, slides carry 25 marks, and originality. So the metrics are content, presentation, slides, and originality, right? And now we'll just do a rough roll call. Do we have Dr. Drishti here? So Dr. Drishti is here. Dr. Meher Kothari is here. Dr. Neha Adlakha. Dr. Neha Adlakha is not here. Dr. Saurabh Patwardhan, I can see he's here. Dr. Leela Mohan, ma'am, is here. Dr. Vatsal Kunwar is here. Dr. Rashmi Tirki is again here.
Dr. Vinay Gupta, Dr. Sai Preeti, Dr. Pratibha Panman, Dr. Savitri Deval.
So Dr. Pratibha is there. Dr. Vinay is not there. Dr. Sai Preeti is not there.
She is there.
Dr. Sai is here, right.
And Dr. Vardhaman, not there.
Dr. Savitri is here, na? Dr. Savitri Deval is here, right. So we have 3 and 2, 5 and 4, 9. And it's 5 minutes per speaker?
Yes, sir.
So it's 5 minutes per speaker. Can we have the first speaker, please? Dr. Drishti Singh.
Yeah, sure. So please make a warning bell at 4 minutes. ठीक है 4 मिनट पे एक वार्निंग बेल एक दे देंगे राइट
Okay, so it's not showing us a 5 here, right?
Yeah, 5
It's showing
is
a
the
4. The timer is not at 5.
Five
Please reset the timer at 5. And please, okay, that one is fine. This one is उल्टा लगा हुआ वो 5 वो 4 दिखा रहा है यार 5 नहीं किया उसने भी
उसका टाइमर यहाँ सेट कर देंगे
5 पे
5 है ना ओके सो कैन वी स्टार्ट
A warning bell at 4 and a long bell at 5. Done. Roger and out.
In this ChatGPT era, digital advancements are reshaping healthcare, including vision assessment. As web-based tools become more prevalent, ensuring their accuracy is crucial. Good morning. Today, I, Dr. Drishti Singh, will be talking on the influence of computer parameters on contrast sensitivity values obtained with the web-based space enrichment contrast sensitivity test. As we all know, contrast sensitivity is the ability to perceive slight changes in regions not separated by definite borders. In measuring contrast sensitivity, we have come a long way from grading charts to letter charts, and now mobile and computer-based applications like Sparks. Sparks is a web-based contrast sensitivity test that can be accessed via the following URL. Here, the patient gets a unique identification number. It is based on gratings and is independent of the effects of literacy. It measures both central and peripheral contrast sensitivity. It measures a wide range of contrast and uses a bracketing technique. Here, the patient is seated 50 centimeters from the computer monitor. It has 4 peripheral quadrants and a central square, with each square having a score of 20, amounting to a total score of 100. So why the current study? There is increasing amount of literature making use of Sparks and many other web-based applications. Therefore, it is important to consider the influence of various devices and validate them. Therefore, our objective was to see the influence of two different laptops, that is MacBook and Surface Pro, on contrast sensitivity values obtained using Sparks. Our study was a prospective observational study that involved 80 healthy individuals free of ocular diseases. The age group was from 18 to 40 years of either gender, with a visual acuity of 6.6 in both the eyes. The exclusion criteria included the use of contact lens or dry eyes, history of any incisional or laser eye surgery in the past 3 months, and any other cause of visual impairment. The testing was done for each patient on both the laptops using a calibrated laptop screen. It was done uniocularly. One demonstration and a practice trial was done. The participant was given a break of 5 to 15 minutes after the practice test. Order of testing was randomized. At least an hour's gap was given between the testing with different laptops. Testing was conducted in a room with fluorescent lighting with no windows. This is a representative case of a 20-year-old male on both MacBook Air and Surface Pro, showing us the different total scores and different values for quadrant-wise score. Coming to the result, data of 160 eyes were evaluated of 80 subjects with an average age of 26 years. Non-parametric tests were employed to examine the correlation between the two variables. A moderate to strong correlation was found between the internal components of Sparks and with the total Sparks score when performed on the same laptop. However, between two devices, the correlation coefficient was weak. Therefore, while the mean difference was small, broad limits of agreement and moderate correlation suggest using the same device for consistent measurement. Therefore, Sparks on a single laptop and the same browser can be used reliably and consistently to know and compare the results. But to ensure comparable results using Sparks on different laptops, it is important to consider the specific display properties of the two laptops. These are the few parameters that could have influenced significantly our results, impacting its accuracy and reliability, paving way for future studies. Thank you.
A very nice study. I think the p-values seem to suggest that there was not much difference between the Surface Pro and the MacBook.
Yes, sir. Not much difference.
And actually what it seems to suggest is that it doesn't really matter what device you're using,
Yes.
but yes, the inter-test reliability
Yes, sir.
is better when you're using the same device.
Same device, yes, and also the same browser.
Okay.
What parameters actually were different in both the devices which you evaluated?
So the aspect ratio of both the computers were different, and also the screen resolution was different. We tried to standardize as many parameters as we could, but these two were the main reasons that could have influenced the results.
So that
Yeah,
would
it
be
could
like
because of a lot of neuroadaptive elements also coming into play.
Yes, sir.
So this thing is out there. It's really an interesting thing. His questions are very valid in terms of first thing is we're just talking about the ocular parameters. First is the display, because the displays are different.
Yes,
It is
sir.
not only that the pixel densities are different.
Pixel densities.
The refresh rates are different.
Yes, sir. The environment, the testing room, it is different every day.
And
So-
you've tested with different browsers, or it is the same? Yeah.
So for this study, we used the same browser, that is Chrome. I downloaded it on the on the MacBook Air. But we also tested, there was a separate study that we did where we compared browsers. So we did find difference in the browsers too.
So the good thing about this study is that it shows that the more devices there are, the more they have to come back to us for validation of the devices.
Yes.
Thank you so much.
Thank you, sir.
Anybody has any questions? Okay, so could you please call the next speakers?
Good morning, friends. I am delighted to present to you the effectiveness of a new product called HALT technology for the retardation of progressive myopia in Indian children. I have no conflict of interest in any products mentioned in this presentation. As all of us know, the prevalence of myopia has been increasing all over the world, including our country. It is almost 5 times increased over the last 10 years and expected to cross 50% prevalence by 2050. What is more concerning is the increase in the prevalence of pathological myopia, which is increasing by 3 times faster rate than the low myopia, more so in urban areas. And thereby, it increases the risk of late ocular complications such as retinal detachment. So the aim of management of progressive myopia in children is to slow down the progression to make sure that these children are saved from the negative impact of pathological myopia in future. To achieve the goal, myopia control in India started with introduction of low-dose atropine back in 2017, followed by introduction of MyoSmart lenses by Hoya in 2021, followed by HALT, which was introduced through Stellest lenses in 2023. As of now, we have few studies available on use of low-dose atropine from India, showing maximum reduction of progression by around 57%. Dr. Shruti Nishant's study from South India shows significant reduction in progression to up to 75% using MyoSmart of Hoya, but such data is not available from Stellest, which is a more advanced technology of spectacle lens. It has higher volume of myopic defocus. So the aim of the study was to find the effectiveness of this new product in slowing down the progression of myopia. It's a retrospective single-center observational study in which 16 consecutive myopic children having a progressive myopia at the time of recruitment between 1 to 8 diopter were included, who had no other ocular comorbidity and astigmatism was less than 4 diopter, with a baseline progression of at least 0.5 diopter per year in the previous year. All of them were prescribed Stellest lenses for full-time wear. Minimum 12 hours per day of wear was required to be included in the study. Before and after the use of Stellest, spherical equivalent refraction was measured and significance value was assessed using the paired t-test. We had 5 patients among 16 who also wanted to continue or rather start with 0.01% while they were using Stellest lenses once at bedtime. This constituted another second group in which there was a combination therapy, and we used group t-test for assessment of p-values. Of 16 children, 6 were females with an average age of 10.5 years plus minus 3 years. Mean myopia was minus 4 diopter ranging from 1 to 8, and mean follow-up was 10 months ranging from 6 to 18 months. The efficacy of Stellest lenses was found to be 87% with a reduction of pre-treatment 0.8 diopter per year to 0.1 diopter progression per year. When we compare two groups, the second group in which Stellest was used along with 0.01% atropine, we found it to have significantly higher effectiveness, however significant in the clinical sense, but statistically it was 0.59 because of small sample size. None of the patients who used combined therapy had any progression. So in all, it seems this new defocus lens has superiority in terms of reduced progression of myopia. The numbers seem to be too good to believe, and of course, why not? There could be limitation in this study, like being retrospective in nature, lack of control group and randomization, small sample and small follow-up, lack of measurement of axial length, and also we did not look at the side effects of use of these lenses or other confounders. However, there are 3 studies available across the world. All of them have shown that defocus lenses are superior to low-dose atropine by at least 10%. So in conclusion, they seem to be better than the existing atropine use. When combined, it becomes even better, and further studies are required with larger sample size. Thank you very much.
Thank you, Dr. Mayer. I think if these lenses are able to halt the progression, they will just justify their name as well. Like we have seen that with atropine eye drops, the patients have not been that compliant. So if these lenses can be that good that as have been claimed, definitely that they could be of great use. Only thing is that the sample size, as you already commented in the limitations, so only like 10 people were from not the mixed group. So that needs to be, I think, be well justified to come up with validated results, I guess. And what are the like side effects that, if you could mention regarding these lenses?
Sir, the potential side effects, there is one study available from Sumita Agarkar from Shankar Netralaya, where they looked at the child complaining of peripheral blur, eye strain, headache, and like in multifocal lenses or EDOF lenses used in intraocular lens segment, they also can complain of halos and the starburst appearances. In our study, none of the patient had this complaint. Not even adaptation time was required in our 16 patients. But in her study, she has shown that around 10% patients can have this complaint, but it doesn't make it intolerable. And after around 2 weeks of neuroadaptation, most of them are able to use it, sir.
Actually, Dr. Meher, I had one query.
Yes, sir.
You see, the proof of the pudding would be if we did a crossover on it. Did the thought of a crossover come in your mind? A crossover or a double crossover kind of a thing?
So right now there are three studies available. One is a randomized control trial in which the patients were, these are expensive lenses, so making them crossover, it's a 18 to 20,000 rupee spectacle lens. Plus it's been there since 2023 only. So getting at least 1 year, ideally 2 years is required, because first year effectiveness is supposed to be higher than the second year's effectiveness for these lenses. So for crossover, after 2 years we will be able to cross them over, but it's a good suggestion for an individual child. However, again, the age of the child has increased by the time we actually cross over
Yeah, so
to new.
that's going to be
So that's a confounder for us, sir.
that's
So
going to be a confounder.
I think RCT, parallel RCT would be a better idea, sir.
Yeah. Anybody has any questions? So I think we could go to the next speaker.
Thank
please.
you.
Thank you
The
very
next
much.
speaker, Dr. Neha. Please.
Pre-myopia, that is, before myopia. This term was introduced as while reducing the progression of myopia is the main target or the research of myopia, preventing the onset of myopia is even a more valuable target. Identification of pre-myopia involves identification of risk factors and an observed pattern of risk growth, eye growth, which indicates high risk of progression to myopia. A very good morning to everyone. Myself, Dr. Neha Adlakha, Associate Professor, SHKM GMC Mewat, and I would like to present a paper on prevalence and risk factors of pre-myopia among preschool age children in a rural tertiary care center in northern India. International Myopia Eye Institute defines pre-myopia as a state of refraction of eye in between plus 0.75 diopters and minus 0.5 diopters in children, where a combination of age, baseline refraction, and other quantifiable risk factors provide a sufficient likelihood of future development of myopia so as to merit preventative interventions. Worldwide, the prevalence of myopia is increasing and has reached up to a level of epidemic. Onset of myopia at an early age can lead to presenile cataract, open-angle glaucoma, and myopic macular degeneration, which is a leading cause of visual impairment. Thus, it is quite important to recognize pre-myopia at an early age. So, this study was conducted so as to identify subjects that are at high risk of developing myopia so as to facilitate myopia in an early age itself. So, what are the changes we want to look for in this study? We want to find out the prevalence and risk factors of pre-myopia in a rural tertiary care hospital in northern India. How did we start? 6,348 children of age group 3 to 6 years were included in the study. The research work was executed after approval from the Institutional Ethical Committee. Informed written consent was obtained from parents of all the participants. A pre-tested semi-structured questionnaire was administered sorry, addressing demographic characteristics and risk factors of pre-myopia. After obtaining complete ocular and systemic history, comprehensive ophthalmological examination was performed, including best corrected visual acuity, cycloplegic refraction, slit lamp adjacent examination, and intraocular pressure. Statistical examination was performed using SPSS software for Windows. Multivariate logistic regression analysis was used to compare the risk factors. In our study, the prevalence of pre-myopia was found to be 58%. It was more common in females due to as there is increased growth spurt in males and increased sports participation and outdoor activity in males and increased near work in females. It was more common in urban population as increased sedentary lifestyle reduced outdoor activity in urban population. Longer sleep duration was protective factor for myopia as sleep focuses on the circadian rhythm. Premature and low birth weight babies are more prone to develop pre-myopia due to maldevelopment of their anterior chamber, thicker lens, and increased corneal curvature, which leads to increased focusing power of the eye, leading to pre-myopia. If there is increased screen time, there is increased risk of pre-myopia, as with increased screen time, there occurs increased accommodation and axial elongation, which leads to increased focusing power, leading to increased myopia. Increased outdoor activity is protective factor for myopia as there occurs increased sunlight-induced release of dopamine neurons from the retina, thus causing protection factor for the myopia. Prevalence of pre-myopia was significantly associated with female gender, positive family history, urban residence, higher parental education, increased screen time, increased near work, reduced outdoor activity, shorter duration of sleep, and premature birth. Management of pre-myopia is important before the child develops myopia. Certain lifestyle modifications like increased outdoor activity to around 80 minutes per day, reduced near work to 2 to 5 hours per day, regular topical administration of 0.025% atropine has been found out to be beneficial. Proper counseling of parents is important so as to understand the condition and the preventative measures. Thank you.
Thank you, Dr. Neha. This was a very nice study, but unfortunately, we were looking for the figures. You've given us your inferences. What the audience actually wants to look at is the data, because you have very laboriously collected the data. And from that data, there are certain insights. Yes, you're talking of, sleep, gender, prematurity, screen time being associated. We just wanted to see how they were associated and what was the interplay. Probably, if you had given us your results, rather than only the inferences, maybe we would have been a lot happier than we are right now. It's a very impactful study. But unfortunately, the take-home messages are your interpretations. We are not able to see that from the data. So that is the limitation of the presentation, but at the same time, nothing taken away from it, because she studied, 6,350 kids. So I think, thank you so much. Anybody has any questions?
The sample size was excellent. As I said, if the data would have been there, it would have been an excellent study. And the interpretations, I think, if you just could justify, that would be good. Like the population was 3 to 6 years old.
Yes.
So it doesn't corroborate with the findings that growth spurt is more in that age group. And all those findings are like more prevalent for the prepubertal age criteria, right? So as I said, the data would have justified your findings. That sample size is excellent.
Actually,
So, yeah.
what she's done is she comes up with multivariate logistic regression. Now that that immediately sits, your audience immediately starts thinking, I want to look at that.
Okay, yes.
So that's where it leaves something short.
Thank you, sir.
Thank you
Thanks,
so
sir.
much.
Thanks.
Sir, could you
Next
please-
presenter, Dr. Saurabh. Oh yeah, thank you.
Hello, yeah. Good morning, everyone. I am Dr. Saurabh Patwardhan, and I'll be speaking on my paper, Changes in Accommodation Facility with Varying Accommodative Demand. Mechanism of eye to focus in order to attain maximum retinal image clarity is called adaptive accommodation, and ciliary muscles are actively involved in this process and which are more prone to spasm as well as exhaustion. Apart from vision related abnormalities, the visual disorders including accommodative and binocular vision issues are significantly higher nowadays in younger adults. As a result of global adoption of digital screen, working distance has considerably changed, wherein users must quickly adjust the accommodation to focus on visual display unit and then relax their accommodation for distance things. This study is aimed to assess the variation of accommodation facility at different accommodative demand distances across refractive errors with fixed target size and testing flipper. So aim is to assess the accommodative facilities in patients with emetropia, low-grade myopia, hyperopia with varying accommodative demand, to assess the variation of accommodation facility at subjective working distance of at 30, 40, and 50 centimeters. So this is a cross-sectional study done over a period of 4 years. The study location was Nandadi Pai Hospital, Maharashtra. Sampling was random. We selected 70 patients, 70 subjects who were visiting OPD of hospital. They were not having any symptoms related to accommodation. Materials used were Wellsite rock card of 6/9 acuity and accommodative flipper. We excluded all patients who were pseudophakic or other problems in the eye. After baseline refractive evaluation, we checked for the accommodative facility. So at varying distances, the use of accommodative flipper of +1, +1.5 and -1.5 is going to raise accommodative demand, and we'll be measuring the number of cycles the patient can clear in a minute's time. Going to the results, the distribution was 56% were males, and the refractive error distribution was 24 emetropes, 28 myopes, and 18 hyperopes. When we come to the results of accommodative facility, we found across the all the groups that the accommodative facility was maximum when we used 30 centimeter as a distance for accommodation, while it started reducing to 50 centimeters. Across the three groups, we found that the myopes, hyperopes had higher accommodative facility, but we found that intergroup, when we studied, there was no statistically significant difference between the three groups. So in the discussion, the average accommodation amplitude of non-myopes were substantially higher in earlier studies than myopes. But in this study, we found that accommodative facility was slightly lower in myopic and emetropic subjects as compared to hypermetropic subjects at all three distances, 30, 40, and 50 centimeter, but it was not statistically significant. Now, though the accommodative facility was higher, again, it was not statistically significant. The binocular accommodative facility was always more as expected as compared to monocular accommodative facility at all distances in all groups. Now, this study showed that the accommodative facility is not significantly dependent on the refractive status, and irrespective of refractive status, the accommodative facility which can be corrected by vision. It is observed that accommodative facility decreases with increasing fixation distance. I think this was never documented. In fact, there are no studies in different distances of accommodation, whether it affects the accommodative facility, so we don't have any normative database as well. So we don't know what is the clinical implication, which should be studied further. Now, accommodative infacility is where the patient has asthenopia, and along with that, as compared to normal, they have reduced accommodative facility. It can be treated by different methods. So the further study can be concluded on these results with larger sample size, and secondly, we can also change the target size in respect to change of distance as well for the accommodative facility measurement. We are still working on how the clinical implication is of this changing accommodative facility over different distance of target. Thank you so much.
Thank you, Dr. Patwardhan. A very interesting question you have thrown up here. In this day and age when we are working at the intermediate distance a lot more than we are working at near, especially with the laptops, the tablets, and all these, the accommodative facility at a larger distance, that really calls for more studies.
Yeah. Yes. So that was the surprising finding. Actually, we were expecting that they might be similar, or patient might be having better accommodative facility at a distant object.
That is.
But it is opposite, in fact. And
Would it be related to your, given that we're looking at an age group of 18 to 26?
yeah, young.
If we you see most of these problems start becoming a problem in the late 30s.
Yes.
So would it really, if we expanded the scope to
Yeah.
a larger age group and
So-
have a subgroup analysis?
Yes, sir. So initially, actually, we wanted to have a normative database for Indian people. That's why we
That
started.
would be a very interesting
Yeah.
this thing.
Because in Shiman, the standard, database shows that for 18 to 26 age group, 11 plus minus 5 is the, standard accommodative facility. But in fact, all our patients had less than that, 8, around 7 or 8 for 30 centimeter distance. And it reduced further on, changing the target. So as you said, we were expecting that at an intermediate distance, they should have better accommodative facility. Why it is less, and whether it actually has any clinical implication, that is, if the patient has less accommodative facility at distance and whether it causes asthenopia as you go, is what we have to study further. One of the reasons for reduced accommodative facility, which we thought of after going through, there is no study in the literature on distance, is that maybe it is the blur, because one of the stimulus for accommodation is the blur. So at 50 centimeters, probably the blur is less. So that's why there is lag of accommodation is more. That means latency for accommodation is probably more, and that's why patient has less facility. So that could be one logical explanation. But we have to see whether we should give certain exercises for those patients who have this lower facility so that it may reduce their asthenopia symptoms. We are also looking into younger age groups now to see whether it has any role in myopia progression as well.
I think it has thrown up a lot of questions, and we need more studies to answer those.
Thank you, sir.
Thank you, sir.
Thank you. Good.
No, Dr. Leela Mohan, ma'am.
If anybody has any questions, please raise your hands side by side.
This side. This podium.
Morning. Thank you, sir. So I'm going to talk about visual acuity improvement by dichoptic therapy in amblyopia. So amblyopia, which is a visual developmental disorder where reduced best corrected visual acuity in one or both eyes in absence of ocular pathology. And we know patching the healthy eye after refractive correction is the conventional standard treatment with good results in children below 3 to 4 years. Often, in the older child, prolonged periods of patching yields little improvement, and compliance is a major factor precluding its use. A new approach based on the binocular origin of amblyopia has shown variable results. In dichoptic training, each eye receives different images separately, and to complete a task, both eyes are forced to work together. And Binox is a cloud-based software for the assessment and treatment using this principle. It allows remote conduct of diagnostic tests and therapy under supervision. So the aim and objectives are to evaluate the efficacy of dichoptic therapy in the management of an isometropic and combined mechanism, that is strabismic and refractive amblyopia, and to study the improvement of visual acuity and binocular functions. So a prospective observational study was done among anisometropic and combined mechanism amblyopic patients who did not improve with glasses and patching, and underwent dichoptic therapy with Binox. From February 2023 to February 2024 in our department in Kerala, in South India. Pathological myopia, previous intraocular surgery, development anomalies and deviation more than 10 prisms were excluded after a detailed history and examination of anterior and posterior segment and looking for binocular vision and stereopsis with TNO, glasses were given and patching done. In case of any deviation less than 10 prisms, prism correction and assessment of binocular vision was done again. And this Binox dioptic therapy methodology was diagnostic assessment is done with the Binox software, with visual acuity, binocular single vision and stereopsis done with the software. And any amount of deviation also was noted. Binox Ambligo program is an AI-based vision therapy based on dioptic principle. Contrast-adjusted images are given to both eyes and with red and blue goggles. Normal eye receives lower contrast image compared to amblyopic eye. The contrast in non-amblyopic eye is slowly increased until they are equal, thus removing suppression of the weaker eye. It consists of 40 sessions, 40 minutes each, 5 days per week for 6 weeks, a total of 30 sessions. So after adjusting calibration, initial assessment was done after 2 weeks of therapy, follow up at 4 weeks and at the end of the therapy. And best corrected visual acuity and stereopsis was done. Statistical analysis was done. There were 28 patients, majority belonged to the pediatric age group, and the majority were anisometropic amblyopes, combined mechanism, and one was accommodative esotropia. 2 had strabismus surgery. Hypermetropia were 7, and hypermetropia with astigmatism 10. This is the statistics. And visual acuity improvement was seen after therapy. With paired t-test, it was statistically significant. There was an improvement of 0.05 in the non-amblyopic eye as well. And stereopsis also improved. There is a definite improvement with the p-value 0.005, and it improved in participants who had a minimum stereopsis. There was significant improvement of vision, even which maintained for 3 months, and in binocular vision also. In a similar study by Abdul et al. In 161 patients, the refractive amblyopia in amblyopic mean change was 0.39 logmar, and with the Mazad course, it was 0.28 logmar. In our study, it was 0.118. There is definitely an improvement in stereopsis as well. The so stereopsis has improved in those patients whom at least minimum was there. And contrary to this, a PEDIG study showed that there was no improvement with binocular stimulation by Digrush iPad program. So to conclude, dioptic therapy is a platform effective in an isometropic and combined mechanism even in adults, which was maintained, and stereopsis also was maintained for 3 months or more. And it is good in pediatric and adult age groups. Thank you.
Thank you, ma'am, for touching upon that topic on amblyopia. Like occlusion therapy remains the mainstay, but compliance has always been an issue regarding that. So for these baby bloomers and Gen Y, Gen Zs, this kinds of technologies like the app-based or computer screen-based where they actually interact, that I think is a good one for compliance as well. Ma'am, like what would be the protocol? Like, do we straight away go ahead with Binox, or first you go on with patching and then follow it up with?
Actually, PEDIG showed that those who already have had patching did not improve with binocular therapy, but we started Binox after waiting for any improvement with patching, at least for 6 months.
So do they both go simultaneously as well? Do we
No.
no.
Once we started Binox treatment, there was no patching along with it.
Age group, like when do we recommend it? Like before 8 years or 7 years? Any
No,
cutoff?
we had
Beyond 8 years?
up to 29,
Up to-
30, we have
alright.
had patients who improved with treatment. It's an ongoing, actually, we have only taken the 29 patients, but we have ongoing good results with the binocular therapy.
Results have been excellent, like the follow-up duration, ma'am?
We
3
have
months
1
you have
year.
mentioned, of
We
1
have
year.
1 year,
Right.
yes.
That is good one, sir.
So, ma'am, basically what we're doing here is we've already tried patching. Those who are resistant to patching,
Yes.
not improving, they move to Binox.
Yes.
And
Those who are willing, not every patient.
not every patient. So those who can afford to move to that, they move to that. And we have 25 is an isometropia and 3 is combined. So basically what we're looking at is an isometropia, it's doing a good job.
Yes.
And you are saying that it is also covering an older age group.
Yes.
So how many patients in the older age group are we looking at?
Actually, 3 patients only, but we are taking up more and more patients because they come after recruitment processes when they are declined with the in the military or in
Yeah,
some,
actually,
yeah.
what's happening with the dicoptics is that there is a multitude of interventions. So it's always a challenge. We would be looking at results from your center because you would be following one particular technique, and uh, it's just like lot of things, lot of patients, different types of patients, different groups of patients, different groups of therapies.
Yeah. We
So.
had been very slow in going because we had a thesis protocol 2 years back when we had 16 patients. Very slowly we started, but when we saw good results, we've been recruiting the older age group also more.
Yeah, we'll be looking forward to further results from you. Thank you so much, ma'am.
Thank you.
Thank you,
Could
ma'am.
we call the next speaker? Anybody has any questions here, please? Dicoptic therapy. We have another speaker for dicoptics, I think.
So Dr. Vatsal is already there, please.
Good morning, everyone. Today I'm here to speak on the topic, the relation of screen time and reading with myopia, pre-myopia, ocular biometric and anthropometric measures in 6 to 7 years old children in Jharkhand. Do you know by 2050 it is predicted that half of the world's population would be myopic, with 1 in 10 being pathologically myopic? It is crucial to prevent myopia and start therapy early to reduce its progression, as myopia is closely linked to visual impairment in mid to late life. More recently, the pandemic control measures, including lockdowns, accelerated the universal adoption of screen-based engagement globally. The aim is to study the relation of screen time and myopia, reading with myopia, pre-myopia, ocular biometric, and anthropometric measures in 6 to 7 years old children visiting Tertiary Eye Care Center of Jharkhand with the objectives to understand the relation between screen time and ocular biometric and screen time and BMI in 6 to 7 years old school children visiting Tertiary Eye Care Center of Jharkhand. It was a hospital-based cross-sectional study held at Department of Ophthalmology at RIO-RIMS Ranchi between November 2023 to June 2024, with 52 school children of the age group between 6 to 7 years who visited the OPD were included in the study. The participants' parents completed a standardized eye health and lifestyle questionnaire reporting eye and vision problems. The parents reported their child's daily screen time with one of the following options. This was the questionnaire that we gave to the parents. The children were examined. The examination involved cycloplegic autorefraction performed at least 30 minutes post-installation of anesthetic and cycloplegic eye drops. The Zeiss IOL Master 500 was used to measure the axial length and the corneal radius. The participants' height and weight were also measured, as can be seen in the photographs. The primary analysis used continuous dependent variables like axial length, spherical power, corneal astigmatism, height, weight, and BMI. Result: there were more female population under our study compared to the male. 60% of the population belonged to the urban area. And you can see from this interesting graph and table that 46% people had screen time of 1 to 6 and 33% of them have screen time of more than 2 hours. Urban area had more screen time. Upper socioeconomic status also had more mean screen time compared to the lower socioeconomic status. 1 to 2 hours screen time had mean axial length of 23.84. And as the screen time is increasing, so is the mean axial length. The BMI is increased, and so is the mean axial length. The people who had mean screen time greater than 2 hours had more BMI. And there was more axial length in the female compared to the male. This shows the table regarding child reading and writing. Participant on screen greater than 2 hours per day had 0.12 diopter more astigmatism than those on screens less than 2 hours per day. High myopia has been associated with obesity or overweight. The relation between screen time and increased with the rule refractive astigmatism was found in line with Tong et al. Children on screen over 2 hours were almost 4 times more likely to be overweight, aligning with the literature where 2 or more hours per day on screen in childhood is strongly associated with overweight and obesity. Conclusion: increased screen time was associated with more myopic power, high axial length, higher with the rule astigmatism, and higher BMI. Myopia and astigmatism frequently coexist. Both were significantly associated with increased screen time, so parents should be counseled regarding screen time monitoring of their children. Of further concern, the ubiquitous use of screens may increase sedentary activity and decrease outdoor activity. The World Health Organization advised limiting daily screen time to less than 2 hours for children 5 years of age and older. Clinical implication: myopia increases retinal detachment. Dedicated educational program aiming to reduce screen time are vital to be promoted. Parents should regulate child phone usage. Thank you.
A very nice study, Dr. Vatsala. You are looking at a very small sample size, 52 children of a very narrow age range of 6 to 7 years, am I right?
Yes, sir.
So the generalizability of these findings is going to be slightly limited. Plus we were also, trying to look at the results. We've again got inferences and the results are not really there. But definitely you've pointed out some very interesting things that, which is in line with what we were expecting, but you've provided evidence for that even in India, more screen time means more obesity. More screen time, interestingly, means higher axial lengths. But, we would be happier if we had more data to go back to. Thank you
Yes,
so
sir.
much. Anybody has any observations or questions, please?
It was more of a cross-sectional study, right?
Yes, sir. And
One
that was the
time.
limitation of my study, that the population size was a little lesser.
And the
This
question,
was a thesis that had been given, and it's a thesis which has been presented.
No, sir. I've observed a lot of patients in my OPD coming with the complaint of watering in the eye, like the small children. So I thought of starting this and...
So you can carry on,
Yes,
maybe
sir.
with a bigger sample size
Yes,
or
sir.
a more expanded inclusion criteria, we could have more meaningful inputs from this.
Yes, sir.
Interesting, definitely. Thank you so
sir.
much.
Thank you,
thank
sir.
you. Dr. Rashmi, please. Yeah.
Good morning, all. My topic is on accommodative disorders in non-presbyopic subject with type 1 diabetes without diabetic retinopathy. According to WHO, India today heads the world with over 32 million diabetic patients, and this number is projected to increase to 79.4 million by the year 2030. Recent surveys indicates that diabetes now affects a staggering 10 to 16% of urban population and 5 to 8% of rural population in India. At the ocular level, diabetes can affect practically all ocular structure in anterior segment. Complication includes corneal dysfunction, abnormal corneal sensitivity, diabetic keratopathy, progressive decrease in density, alteration of the corneal nerve, and clouding of the lens at an early age. In the posterior segment, patients with diabetes can experience diabetic retinopathy, neuropathy, glaucoma, and macular edema. Aim was to assess accommodative function in non-presbyopic with type 1 diabetes mellitus. This study was observational, cross-sectional study. Duration was from September 2023 to August 2024. Total sample size was 24%, 12 diabetic and 12 non-diabetic. This was conducted in OPD, Rio Rims, Ranchi. Demographic details: uncorrected visual acuity, best corrected visual acuity, accommodative examination, ocular examination, personal history, drug history, medical history, and surgical history were noted down after taking consent from patient. template was generated using MS Excel sheet, and data were analyzed using SPSS software version 23. Table 1 is showing demographic details of diabetic and non-diabetic groups, where we can see all parameters were equally sensitive. Table 2 is showing ocular examination of patient. Table 3 is showing accommodative variable and classification of the subject according to normality value. Amplitude of accommodation in a right eye is 7.32 plus minus 2.64 in right eye. In left eye, it was 7.65 plus minus 2.64. In non-diabetic group, it is 9.90 plus minus 2.40 in right eye, 9.96 plus minus 2.28 in left eye. Accommodative facility in diabetic group was 7.05 plus minus 4.92 in left eye. In right eye, it was 7.54 plus minus 5.16. Both eye, it was 7 plus 9.39. In non-diabetic group, it is 11.13 plus minus 3.93. In right eye, 11.07 plus minus 4.14. In left eye, 10.75 plus minus 3.59 in both eye. NRA was 2.45 plus minus 0.45 in diabetic group, and it was 2.40 plus minus 0.44 in a non-diabetic group. These findings indicate that diabetes mellitus impacts the majority of the parameter used to evaluate accommodative function. The amplitude of accommodation and amplitude accommodative facility were significantly reduced, while negative relative accommodation was higher in the type 1 diabetes population than in the non-diabetic group. The diabetic group exhibited more accommodative insufficiency compared to the non-diabetic group. A relationship was observed between the duration of the diabetes and amplitude of accommodation, accommodative facility, and negative relative accommodation, but no such relationship was found with HbA1c levels. These are the references. Thank you.
Thank you, Dr. Rashmi. So it was a cross-sectional study or a comparative study?
It was a cross-sectional study.
Okay. So cross-section only for non-plus biopic type 1 diabetes,
Yes,
right?
Very interesting findings. You are suggesting that the accommodation amplitude as well as the accommodative factors are related, are associated with duration of diabetes, but not with HbA1c levels. So not with the control of the disease, but with the duration of the disease.
Yes,
So basically, normally what we do is we say that, duration of disease, the microangiopathy and the neuropathy, so probably some interplay is going on there. So probably you need to look at it more. Interesting study, interesting findings, but more work required. Nice study.
Thank you, sir.
Dr. Vinay is here.
Good morning, everyone. First, I would like to thank the scientific committee for providing me this wonderful opportunity to present over here. Today, I'm presenting a study which aims to evaluate efficacy of DIMS spectacles among progressive myopic Indian children. I do not have any conflict of interest or financial disclosure to declare. So first, before we go into the study, why we need such studies? A lot of studies recently done shows that the prevalence of myopia had been increased, including in India, and the prediction analysis also shows that trends continue to happen in next 2 to 3 decades. So if we could slow or limit the extent of myopia progression, which has reduced the risk of development vision-threatening disease as well as improving the quality of life. So generally and currently, we have pharmacological or optical interventions, atropine, ortho-case contact lenses. Among Indian subjects, atropine 0.01% already had shown a good efficacy by reducing the myopia progression by 54%. DIMS had shown promising results in European and Chinese children. That's why we planned this study, which aims to assess the effectiveness of these spectacles in preventing childhood myopia progression among Indian children. So just to give you a brief outline about the design, so DIMS is based on the myopic defocus, which is imposed on both central and peripheral retina. It is composed of central clear zone, and in the periphery, there are some myopic defocus island distributed in certain honeycomb-like structure over 33 mm area. And each island is providing defocus of 3.5 diopters. So in our study, we took children 6 to 14 years of age with documented myopia progression of 0.5 diopter in the previous year and -2 diopter to -6 year. It's a single-centric study. And the CTRI was taken, ethical approval and informed consent were also taken. So the primary outcome measures was change in the rate of myopia progression from baseline to 1 year follow-up. Also to evaluate the change in the spherical equivalent error and the change in the other ocular biometric parameters. So we did cycloplegic autorefraction plus then following by the subjective acceptance, and all the biometry was done using AIOS 700. So all the analysis was done using SPSS software, and we clustered the data from the both eyes of the same patient pooled using robust standard error. P-value less than 0.05% was considered statistically significant. So generally, when the patient came, we took the history, did the basic ocular examination, anterior cyclic examination, fundus examination. If we found normal, then we performed cycloplegic refraction, then we did all the measurements. Afterwards, based on our inclusion-exclusion criteria, we enrolled it in the program, then we advised him spectacle at least for a year, and then after 1 year follow-up, we did all the investigations again, and at the time, and then compared the results from baseline to the 1 year follow-up. So in our results, we took all 40 children, which has a mean age of 8.3. The mean myopia progression rate at the baseline, that is at the time of enrollment, was 0.65 plus minus 0.21 diopter a year. And at the 1 year follow-up, it was reduced to 0.27 diopter plus minus 0.16 diopter. AL change from their change in AL is 0.15 diopter. And we did not find any correlation between AL and SCR. And also, there is no significant difference noted for change in any other ocular bioparameter like anterior anterior chamber depth, keratometry, or lens thickness. Also, we did a correlation. The treatment response is here considers the rate of myopia progression at the end of 1 year after DIMS spectacle wears. So we just found significant correlation from the age. Otherwise, there is no significant correlation obtained based on any personal characteristics, that is baseline refractive error or myopia progression or gender or any number of myopic parents. Mean adaptation time, we at the 2-week follow-up, we generally ask the children about the adaptation period difficulty in near vision or any peripheral vision, which is noted in certain studies. So generally, the parents have reported that within 2 to 3 days, the children got good adapted to these glasses. There was no major side effect observed during the study period. There are 3 children which continue to progress more than 0.5 diopter a year even after the intervention. The proportion is very less, so we couldn't draw the direct correlation, but generally we didn't found any significant difference in their characteristics as compared to the other children who responded well to the treatment. So in our study, we found 58% reduction in the rate of myopia progression, which is similar to 57% reduction which is observed among Chinese school-age children. Also, the AL in our study, which is shown 0.15 mm change during 1 year, it is also similar to Zhang et al. Reported 0.16 mm. The treatment response is not affected by any personal care except age. We found older children getting better response in the older children. The the effectiveness of DIMS lenses may be due to the continuous myopic defocus, which is better explained in the next diagram. So generally, the theory is that in corrected myopia, the light ray is focusing in front of the retina, and in traditional single vision, the central visual focal on the retina. However, the peripheral ray is focused behind the retina, creating a hyperopic defocus. And eye reacts on this by increasing axial length. So correction like DIMS, they provide a myopic defocus and mimic kind of artificial retina. And most of the current theory suggests this is the preferred correction as to slow down the myopia progression. So this is, to best of my knowledge, is the first prospective interventional trial which is reporting the efficacy among Indian children. And also first study evaluating impact of DIMS spectacles on other biometric parameters. The limitation is that we didn't define peripheral refraction. Also, we didn't include any control group. The conclusion is the DIMS spectacles is found effective in slowing myopia progression among school and children. There is no adverse event reported. However, further research is needed to assess any sustained and long-term impacts. There are certain references. Thank you for your attention. Please, you can connect to us for any further discussion and suggestions. Thank you.
So very interesting study. You're saying that the spectacle use, the dose response,
Yes.
it is not associated with the amount of refractive error at the start of therapy.
Correct.
It is not related to the age at which the therapy starts.
It's slightly, the correlation we found slightly significant with the
Okay.
age. We found in older children, the
You're finding a better response compared to
Yes.
the younger children.
Yes.
Okay. And you don't want to assess the baseline myopia progression because that is not associated how much it is going to slow down. You cannot predict that.
Yes.
Okay. So this is, this sounds more like a one size suits all, fits all therapy. So very interesting. So anybody would be able to prescribe that. But yes, the jury is still out on that. The good thing is that this is the first one that we've got from India. And there's been a lot of interest since, I think, 2020 on these particular set of lenslets. Any observations? Anybody has any questions?
Like as compared to atropine eye drops.
Yes.
So how will you compare these results? Like 58% reduction with
Yes.
these lenses, right?
So in our
Almost
study,
the
the
same.
premium IITM study, I was a part of that. Fortunately, I was a part of that study. So the difference is that in that first study, we did the placebo-controlled trial. So we are the 54% results which we obtained in that study. It is in comparison to the children who is on placebo. Here we didn't have the control group. Here are taking the progressive children's only. So the comparison of the same children. So it might not be justified to directly correlating both the results at the same time.
Okay, thank you.
Okay, I think we're going to run short on time, so we're going to cut short next. Dr. Sai Preeti, please. And could Dr. Pratibha remain ready? Stay there. Dr. Sai, we're not going to ask you too many questions because we're running short on time now.
Good morning, everyone. My topic for today's presentation is comparison of amplitude of accommodation determined subjectively and objectively among university students. Ethical clearance was obtained from relevant ethics committee before commencement of the study. There are no financial obligations associated with this research. Accommodation is the ability of eye to focus on objects at close distance. Accommodative amplitude is the amount of accommodation exerted to move focus from the far to near point. The subjective methods used in this study are push-up, pull-away, minus lens methods, and objective methods used in this study are dynamic retinoscopy and Pascal heterodynamic retinoscopy. The objectives of the study is to compare the difference in amplitude of accommodation using subjective and objective techniques in patients with different refractive errors, to compare the values of amplitude of accommodation obtained from subjective and objective techniques. It's a cross-sectional observational study. Study population is 60 university students between the age group of 18 to 30 years who met the eligibility criteria and consent were taken. The eligibility criteria is emetropes, myopes with early onset minus 0.5 diopters to minus 10 diopters, 13 years or earlier. Late onset minus 0.5 diopters to minus 3 diopters, 15 years or later. Hyperopes, an age group between 18 years to 30 years, and subjects having visual acuity 0 log units in each eye. All the history was taken, visual acuity measurement was done. Orthoptic evaluation like cover uncover test for near and far distance is done. Slit lamp examination, indirect ophthalmoscopy was done. Near point accommodation using RAF ruler with an average of 3 readings were taken. Amplitude of accommodation for the subjective methods like push-up, pull-away, minus lens methods, and objective methods like dynamic retinoscopy, Pascal heterodynamic retinoscopy was done. Statistical analysis was done using ANOVA to compare amplitude of accommodation in objective and subjective techniques with emetropes, myopes, and hypermetropes. Pearson correlation was used to find relation between each objective and subjective strength of correlation analyzed using Evans guidelines. This table shows the mean values in emetropes in different methods like push-up, pull-away, minus lenses, dynamic retinoscopy, and Pascal heterodynamic retinoscopy. All these values were significant. And this table shows the myopes. Even this table shows it is significant. And these are the values in hypermetropes. So this is a bar graph showing the mean amplitude of accommodation of dynamic retinoscopy in both the right eye and left eye for emetropes, myopes, and hypermetropes. This shows that myopes has higher mean values compared to, then comes the emetropes and hypermetropes for dynamic retinoscopy. And the second one shows for Pascal heterodynamic retinoscopy. This also shows myopes are having the higher mean values than emmetropes and hypermetropes. This bar graph shows push-up technique, which also shows myopes having higher mean values than emmetropes and hypermetropes. So this shows the pull-away technique, where myopes are higher than emmetropes and hypermetropes. And the second one shows for the minus lens technique, where the myopes again are showing the higher values than emmetropes and hypermetropes. So in our study, the push-up technique produced the highest amplitude of accommodation, significantly exceeding other methods, similar to Chiranjeev Majumdar et al. Study. The present study showed a significant difference in amplitude of accommodation among emmetropes, myopes, and hypermetropes when using push-up, then pull-away, then minus lens, and the dynamic retinoscopy and the Pascal heterodynamic retinoscopy. Our study showed a higher amplitude of accommodation in myopes, followed by emmetropes and hypermetropes, which is similar to Chiranjit Bal et al. Study. So to conclude, this study concludes that mean amplitude of accommodation obtained using push-up technique was higher when compared to all the other techniques, and the amplitude of accommodation was higher in myopes than emmetropes and hypermetropes. These are my references. Thank you.
Thank you, Dr. Sai. I think your conclusion would have been much better supported if you had carried out a post hoc analysis after the ANOVA. So the conclusion is based on a visual examination rather than a statistical analysis there. Yes, you have one group is distinctly different from the other groups, but which is the distinctly different group would require a post hoc analysis in this one. And your observation, sir?
Yes, like the minus lens technique, you said that both have unequivocal results, right?
Yes, so the minus lens technique is when we last the
So
patient.
it was like unequivocal for both hypermetropes, myopes. I think it did not vary.
Yes, sir.
Okay, so I think as sir said, apart from the ANOVA, you could have just compared and come out with a conclusion which one to go ahead with, like for unequivocal results maybe, right?
It's a good study. You see, it requires a little bit more analysis. Again, correlation was not the best parameter to use, because correlation will be affected by the extreme values. The end points are going to affect the value of the correlation. So probably there are other measures which have, because there is a lot of work going on in the center, which is not picked up by correlation as being used as a measure. But definitely interesting, you need to work more on this. Nice study. Could we have the next speaker, please? Thank you, Dr. Sai. Dr. Pratibha Panmand is going to talk about peripheral refraction in Indian pediatric population and effects of myopia control treatment.
Good morning, everyone. I'll be talking about my paper on peripheral refraction. We know that myopia prevalence has increased worldwide, and there are several extrinsic and intrinsic factors which play a role in myopia progression. However, the theory which has gained more attention in the recent decades is the theory of peripheral refraction. Hooger-Hyde et al. In 1975 had proposed a certain specific peripheral refraction pattern in children who progressed to myopia. They noted that myopic children had hyperopic defocus, whereas emmetrope and hyperope had myopic defocus. So peripheral hyperopic defocus was caused actual elongation and thus lead to myopia progression. There are several treatment options which are based on this peripheral refraction, peripheral defocus theory, like the Hall technology, the DIMS, the ortho-K and the soft ortho-K lenses. Now these lenses, when they're placed in front of the eye, they reduce the hyperopic defocus and thus helps to slow down the myopia progression. So the purpose of our study was to study the trend of the peripheral defocus in this pediatric population and the effect of myopia control strategy. This was a prospective observation study done over a period of 2 years after ethics clearance. So we had 578 pediatric patients in the age group of 4 to 17 years with visual acuity of 6/8 or better in each eye. We excluded children with ocular diseases, ocular surgery, or systemic diseases which affect the eye, children with delayed development and who did not cooperate for the testing. Detailed eye examination was done in all, including cycloplegic refraction, and axial length was done on IOL master. Peripheral refraction was done using an open field autorefractor where measurements were taken at 20° and 30° in the horizontal meridian and 20° in the vertical meridian. And this is how it was documented. So our primary outcome was to study the pattern of the peripheral refraction in each of these groups. And the secondary outcome was to study the effectiveness of myopia control treatment. And we defined stabilization of myopia as refraction less than or equal to 0.5 diopters or less than or equal to 0.30 millimeters axial length progression over 12 months. The central spherical equivalent on the PR was used to categorize the refractive status into different refractive error groups. So we had more female preponderance with more moderate myopes followed by mild myopia, high myopia, emetropes and hyperopes. So peripheral refraction pattern was analyzed using the one-way ANOVA test in the right eye, and we noted that only emetropes had more hyperopic defocus, and the maximum defocus was noted at nasal and temporal 30 degree, wherein the other refractive errors did not show any significant difference in the refraction pattern, the defocus pattern, sorry. Coming to the myopia patient, we had 506 children with a mean age of 11.19 years and mean axial length of 24.63. 18% has a positive family history of myopia. So the treatment was also influenced by various other factors, like children less than 10 years were treated aggressively, all myopic progressors were treated. Children with hyperopic defocus was given an option of defocus glasses and ortho-K, and myopic defocus was given an option of LDA. All fast progressors were on LDA, defocus or ortho-K. Slow progressors were only given lifestyle changes with single vision glasses. Positive family history was treated aggressively. In children who did not respond to the previous myopia control treatment option, an add-on combination was done. And the treatment was also influenced by cost effectiveness, long-term drop installation, and willingness to wear the contact lenses. So we had 435 progressors, and note here there were equal distribution of hyperopic and myopic defocus. Amongst the children who were on defocus glasses, 34% came for follow-up and 97.4% were stable over 12 months after treatment. Amongst the LDA, 57.5% patients followed up, 47.8 were stable. However, 52.1% had to be put on add-on treatment either in the stepping up of LDA or defocus or combination. Amongst the ortho-K lenses, all patients were stable at the end of 12 months. So we know that studies done by Donnell et al., Jamal et al., and Han-Yun Sun and Muti et al. Have shown that myopic children have peripheral hyperopic defocus as compared to emetropes and hyperopes. However, our study highlights a distinct peripheral refractive profile. Peripheral refraction was first implicated as a risk factor for onset of myopia, and our study deviates from this trend. A subset of myopic children showed myopic defocus, and this could be attributed to the ethnic and genetic variability and unique environmental and lifestyle factors. Myopia treatment should be tailor-made. Compliance and patient preference is very important in the success of myopia control treatment. Hyperopic defocus may not uniformly contribute to axial elongation in all the cases. So my take-home message is peripheral refraction profile add a valuable insight, but it cannot be a sole factor in decision-making. Myopia control treatment should be personalized. A long-term follow-up is important for better understanding of these treatment options. And further studies are required as there is very limited data available in the Indian population. Thank you. These are my references.
Thank you, Dr. Pratibha. So like when we are selecting for these defocus lenses, so what will you recommend? So do we have to assess this peripheral refraction part?
So as per our study, what we realize is actually peripheral refraction is not a criteria, because we had equal number of progressors with myopic as well as hyperopic defocus. So I think one can go ahead and do these defocus glasses in spite of peripheral refraction, because in our study it is not showing anything significant here.
Right. Thank you, sir. Your take.
Actually, what she has focused on is we've been assuming that the defocus, the cause for the progression, and you've just debunked that. I'd like to see that's not a secondary outcome measure, it's the primary outcome measure of our study. So it is adequately powered. That means you've actually worked it out backwards.
Yes.
And definitely we'd like to, have you published?
No, we are yet to write it because we have
Because, we would definitely like to look at these results.
Yes, absolutely.
Because we need to look at the normative database for India.
Yeah.
Maybe we're behaving differently, maybe those guys are behaving differently. And you see, at the end of the day, it is empirical evidence. What she's given us is empirical evidence.
And lot of these defocus glasses, actually, they do not do peripheral refraction. In their criteria,
They don't do it at all.
Yeah.
It is just, prescribed. That's what I was focusing, one size fits all. So let's look at it. The jury's out on it. Actually, we've run short on time. We'd love to discuss that one.
Sure.
Can we have the next speaker?
Dr.
Thank you so
Savitri,
much.
please.
Actually, we got the session late, and I'm sorry we have to. I know the audience is a little dejected because there are very interesting studies which we cannot really discuss.
I'll start, sir. So, good morning, everyone. I'm Dr. Savitri, and I'll be showing our study on visual outcomes of latest software-based dioptic therapy for amblyopia management. We don't have any financial interest. So, amblyopia, as we all know, is a neurodevelopmental disorder affecting the visual cortex with no identifiable pathology of the eye or the visual pathway. There is impaired visual development in one or both the eyes. It impairs the visual acuity, the stereo acuity, the pattern recognition, and reduces the sensitivity to motion and contrast. So, early diagnosis and treatment is imperative. So, first of all, to correct a refractive amblyopia, we have to cater to correcting the refractive error first by means of glass or contact lens. Then there is addition of either patching or atropine depending on the case. But obviously these also have their own set of problems like residual amblyopia, non-compliance, limited efficacy, side effects of the atropine therapy, and poor response in older children and adults. And also there is risk of relapse of the amblyopia after treatment cessation. So due to the shortcomings, we have binocular-based dioptic therapy. It has come into limelight in the last few years. Studies have shown that the depth of amblyopia has been positively correlated to the degree of binocular imbalance. The affected individuals show impaired stereo acuity, abnormal binocular summation, and that the binocular cortical communication still persists in the subjects with amblyopia. So, basically it is based on dual colors, the red and the blue separately for dissociation with the red for the amblyopic eye. Essentially it promotes binocular cooperation and increases the cortical plasticity. It offers simultaneous and separate stimuli to both the eyes with the dominant eye receiving an image of the lesser contrast. So this is when the images from the two eyes are superimposed, the subject perceives a single percept with elements presented to both the eyes separately. Literature has shown evidence that it improves the visual acuity, the stereopsis, and the binocular function also. The purpose of our study was to evaluate the visual outcomes of a 12-week dioptic therapy in the amblyopic eyes. So we undertook this retrospective observational study wherein 35 patients were enrolled. Patients who had completed 12-week therapy regimen and consenting for the study were included, whereas those having coexistent severe ocular pathologies, unable to complete the 12-week regimen, or those who have had another type of amblyopia therapy done in the last 2 weeks and not consenting for the study were excluded. PAIR-T test was used for the data analysis. So BCVA, stereopsis by Titmus fly test, and binocular function by Wirth 4-dot test were assessed pre and at the end of the therapy. We have the binocs, which uses the anaglyph glasses, which has 3D stereoscopic effect. Regarding the therapy protocol, so patients having either unilateral or bilateral, both kind of amblyopia were enrolled. There should be no squinting, but at the same time, mild to intermittent squinting with good control is still acceptable. The patient needs to have a central fixation, and there should not be any neurological issue, and there is no age bar. Coming to the clinical evaluation, so a detailed history and complete ocular examination is mandatory. The therapy session consists of 30 to 50 minutes with a minimum of 5 days a week and total of 60 sessions. So both eyes are individually color calibrated first. The patient parameters like the IPD, refraction, distance and near vision are entered. Then there are different types of activities followed by assessment. There are different types of games, and this is how the final results look like. So coming to our results, out of the 35 patients, we found that 71% had anisometropic, remaining had isometropic amblyopia, whereas 23 had unilateral, that is 65%. The age ranged from 6 to 30 years with a mean age of 13 years. We found significant improvement in the mean BCVA from pre-op 0.5 to post-op 0.3 logMAR scale in the anisometropic group and from 0.4 to 0.2 in the isometropic group. The non-dominant eye showed significant improvement with the mean BCVA change of 0.3 logMAR in the whole sample, whereas the dominant eye BCVA only improved significantly in the isometropic amblyopia group. Additionally, 85% patients showed improvement in the stereo acuity. including 11 who had unmeasurable stereopsis before the therapy, although the p-value for this was not statistically significant. Binocular function improved in 6 out of 16 subjects who had pre-therapy suppression, and there was an overall average BCVA improvement by 3 logMAR lines in the whole sample. So to conclude, it's a viable and non-invasive alternative. It has shown improvements in visual acuity, stereopsis, and binocular function, and it enhances patient adherence and outcomes. It's a promising step forward to treat amblyopia and binocular vision anomalies. Thank you for your kind attention.
Ma'am, could we go back to the slide where you're showing us isometropic and an isometropic improvement?
Yes, sir.
With the p-values? Yeah. You are saying that the improvement, see, it's 0.46 to 0.24 and 0.55 to 0.30,
Yeah,
isn't
right.
it?
Yes, sir.
So that seems to improve by 0.25, has a spread of 0.29, 0.25. So roughly the same kind of a data spread out.
Yes, sir.
And this is 0.22. So 0.22
Yeah,
to
right.
0.25.
Yes, sir. Yes, sir.
Clinically, probably, we're trying to stretch it too far. It's just that they're almost similar. So
Yes, sir.
isometropia
Yes.
and isometropia.
Yes, sir. We
you said
actually compared both the groups.
yeah, no, you made an observation that
Yes, sir.
it is more in isometropic.
Yes, yes, definitely.
It is
In-
almost equal in both the groups according to your data here.
But we have compared the dominant and the non-dominant also. The non-dominant eye showed improvement in the both. But
Okay.
individually, if we see in the in the isometropic group, the dominant eye seems to work better.
Okay.
So
So
we have-
basically now we've
This
got a
data
situation.
is for both the eyes
This
binocularly.
is okay. This
one.
is
Yeah.
and so basically we need to look at a subgroup analysis of
Yes, actually,
of
sir.
the dominant eye.
Yes, sir.
So
So actually,
Yeah.
there are multiple arms, and we have been trying to correlate many of them. But these are our
yeah,
primary
that's what I was
results.
saying. You see, dichoptics is like very happening. The problem is there is too much choice,
Yes.
too many things going on. So it's very difficult to compare different algorithms.
And we have other patients also enrolled, but they have undergone similar therapy like patching previously. So to prevent any confounding factor, we have just confined these 31 patients who have just received binox therapy. That's all.
Yeah, so it's very interesting that I think we need more studies coming in.
Yes, sir.
I think we're hopelessly short on time. Anybody has any questions? Any of the speakers, you want to ask a question to any of the speakers? Thank you so much. Over to you, sir.
So we conclude this session. Thank you, Dr. Jatinder Bali, sir, and all the speakers for very good papers that we had, a varied kind of papers. But yes, one observation from sirs, and that it would be like good if we could have more of optics and contact lenses as well, rather than focusing mainly on myopia, though myopia remains of prime importance, as we know. So thank you all, and if we I can for the next session, the chairpersons are please
Do we
invited
have the
to
chairpersons for the next session here,
take
please?
the
Please, ma'am.
please, ma'am. And if the presenter is still here, we can have a group photo maybe.
Yeah, can we have the presenter, the speakers? All the speakers, please come up.